Thank you very much. I'm delighted to be here for this, I think, strategically very important meeting. I'm going to talk about a theoretical framework for understanding health provider behaviour, and I should say as a basis for changing health provider behaviour. And what I've got to say really sits in Ralph's diagram that he presented earlier today, where there were individual patients and providers that were part of the bigger picture. And if we do want to implement evidence, then individuals need to change their practice by definition, and the issue is how best to do it. First of all, this is a general problem, not just this area, and to give a couple of examples of studies, in the Netherlands, 30 to 40% of patients didn't receive evidence-based healthcare, and another example you're probably aware of that up to a quarter received care that was unnecessary or even harmful. And the issue is what to do about this situation. It's obviously a massive waste of the investment in biomedicine and in effective treatments when it isn't implemented. So, as I said, improving implementation depends on people changing their behaviour, and I'm going to bring some behavioural science into the mix. And that's a whole range of different individuals. It's not just providers, but managers, ancillary staff, commissioners, policymakers, politicians. And interventions to improve implementation have achieved modest and variable success. And for those of you who don't know the journal Implementation Science, I commend it to you for studies, an open access journal. There's a science of behaviour. However, behavioural science is seldom used to inform intervention, design or evaluation. And I think it's something to do with the nature of behaviour. I know that I can't perform open heart surgery or design bridges, but everybody behaves, everybody sees other people behaving, and everybody's got their own theories. We've been hearing about tacit knowledge about behaviour. Unfortunately, often they're not helpful and they're not correct. Otherwise, we wouldn't need behavioural science. I'm going to just take one example of provider behaviour to illustrate some methods to help understand behaviour with a view to changing it. And I'll take just the example of PrEP that we heard Chris mentioned earlier, that there are several studies. The evidence shows that it's effective. And we know that for that to be implemented, it will require prescription delivery by providers who are not HIV specialists. In terms of the implementation, it's very low. Now, why is that? I haven't done a systematic review, but I've looked briefly at some of the literature. There's some explanation around the issues of knowledge, skills and beliefs. So studies conducted in the last couple of years show poor knowledge of the intervention, uncertainty about how to deliver, not convinced of either efficacy and or effectiveness, and then issues to do with identity. It's not people's responsibility, others are not doing it, why should they do it? So we have some evidence around that area. We also have some evidence about concerns about risks, toxicity, side effects, drug resistance, about stigmatization, risk compensation, that people will engage in more risky behaviors, less money for other HIV prevention. And we also know something about what predicts the low prescribing of PrEP. There have been studies showing that low knowledge predicts, perception is not effective, and negative attitudes towards delivering it. So how do we translate this knowledge into effective interventions to change the situation? A key thing is to start by understanding the behaviour in context. So thinking about what needs to change for the behaviour to change. And I would really emphasise the word context, which I think picks up on what was covered in the last talk, that it's about having the research findings, but also thinking about how that plays out within any particular context. So I think if you take away one thing from this talk, it is this point about don't intervene without really understanding the nature of the behaviour that you're trying to change. And then use this behavioural diagnosis to design the intervention. And I'm going to say something about intervention functions and specific behaviour change techniques. To give a medical analogy, if you go to see your general practitioner, you don't expect to be prescribed treatment without a thorough assessment of your problems and a diagnosis, a medical diagnosis. Well, similarly, in terms of changing behaviour and implementation, too often people jump in with suggested solutions without really starting from that kind of diagnosis. Now, let me just say something about more traditional approaches to designing interventions. A colleague of mine from the UK, well-known implementation researcher, talks about the lousyass principle guiding the design of many interventions. Have people heard of the lousyass principle? Doesn't look like it. Well, not surprising. It stands for it seemed like a good idea at the time. And unfortunately, you know, when you do ask people about, well, why did you choose that intervention? It kind of boils down to variants of that theme. So I want to present a slightly alternative approach, drawing on behavioural science. And as I said, it starts with why are behaviours as they are and what needs to change for the desired behaviours to occur. And to help answer that question, I'm going to present a model of behaviour, which we call Kombi. And this posits that behaviour occurs as an interaction between three necessary conditions. Now, just do a thought experiment for a few seconds in your head. The clues are C-O-M. So these three words begin with C and O and N. So I don't know if you can guess what they are. I'll give you another clue that in your legal system, to prove that somebody's committed a crime, you have to prove three different things. So hopefully you've got there, but if not, anyway, here we go. So the first is capability. People have to have the capability in order to behave. The second O is opportunity. And the third you've probably got by this time is motivation. And you'll see that I've presented these not as a list, but with interacting arrows. That this is a system, a small system in its own, and one can intervene in one or other of these parts, and it can have knock-on effects on the other. So by changing capability, for instance, you can increase motivation. By changing the behaviour, it can have knock-on effects on all of these things. So what you want to do is to create a kind of positive cycle. Now, I'm going to make this a little bit more complicated, but even this model, a lot of people work with this. You know, policymakers, people who are not scientists, can really understand this. But to get just a little bit more complicated, capability can be psychological, knowledge and skills, or physical ability to enact the behaviour. Motivation can be what's called reflective or automatic mechanisms. Haven't got time to go into this, but very simply, reflective is the rational, conscious, self-aware choices that we make, that we all think is what guides our behaviour. The reality is that it's a much evolutionary older bit of our brain that drives our behaviour, the more automatic mechanisms, which are drives, impulses, emotions, habits, etc. Really important to be aware of that. So studies that look at knowledge, attitudes and beliefs, this is only looking at this one part of motivation and forgetting all the rest of this system. So it's very partial. An opportunity is physical environment, but crucially the social environment. We're all social animals, and the behaviour of people around us is incredibly important. Okay, so we've got a little bit more complicated, and these can be further subdivided into what are called theoretical domains, and these allow a more fine-grained analysis of the implementation problem, which leads to a more fine-tuned intervention. In implementation science, you can see this work, and I'm going to present this, and it's just an elaboration of the basic Kombi model. So we have 14 domains that sit within capability, opportunity, and motivation. And these may be barriers or facilitators to the desired practice. And what that does is identify areas to change in designing interventions. And there's a total of 14 domains that I'm going to quickly show you. And these can be used to structure ways of gathering evidence about an implementation problem. And one can gather evidence by semi-structured interviews, by focus groups, by looking at documents, by observation. Different sets of data can inform it. So physical capability is just maps onto physical skills. I should say that the theoretical domains framework was generated through a partnership between behavioral scientists and implementation researchers, using theories and constructs of behavior change, going through certain processes to end up with this kind of integrative framework of 14 domains to allow those who aren't behavioral scientists themselves to at least use a comprehensive theoretically based framework when they assess implementation problems. And so what we're doing here is mapping on to this Kombi system. So psychological capability can be broken down into knowledge, various kinds of skills, ability to regulate one's own behavior. Then we have the reflective motivation, and there's quite a lot of domains here. But see, even within this, we're not just talking about knowledge, attitudes, and beliefs. We're talking about many more things. Automatic motivation, reinforcement, an incredibly powerful driver of human behavior, and emotion, often understudied. And finally, physical opportunity and social opportunity have parallel domains. So I've shown you sort of 3 levels of complexity in terms of how fine-grained one wants to go in terms of using this kind of framework. But what it does is it allows you to start looking at the whole picture, not just it seemed like a good idea at the time. Okay, so if you think back to the findings that I showed you from the literature, we can map those on to this sort of framework. So poor knowledge of the intervention, not being sure how to present it as a skills issue, and not my responsibility is to do with identity, uncertain about how to do this, belief about capabilities, concerns about side effects, stigma, not being effective, beliefs about consequences, and then we have the concerns also having an emotional aspect, lack of healthcare capacity, training and guidelines were mentioned, and believing that no one else is doing it, so they shouldn't either. So you can see that these disparate empirical findings can be brought together into understanding it theoretically, and I'll show you in a moment how important that is in terms of then suggesting how best to intervene. So in terms of designing interventions, if one can draw on theory, one's more likely to have identified the mechanisms of action that need to change and therefore be effective. And I'm going to show you another framework which helps in moving from that behavioural diagnosis that I've shown you towards intervening. So here's the Kombi model that I presented before, and here I've just put it into the hub of a wheel. It's a 6 segments, but put into the hub of a wheel, and I'll show you why in a minute. In intervening, again, consider all the options. Frameworks make life a lot easier. It helps you to think in a structured, systematic, and holistic way. However, we need a framework that is comprehensive, so you don't miss options that might be effective, that's coherent, so you can have a systematic method for intervention design, and that's linked to a model of behaviour, so that you can draw on behavioural science, and crucially, that is usable by and useful to policymakers, service planners, and intervention designers. So, do we have such a framework? I thought, well, it's an empirical question. I did a systematic literature review and identified 19 frameworks of behaviour change interventions. And these were related not just to health, but environment, culture change, social marketing, etc. Evaluated them according to the 3 criteria I just presented, and none met all of them. So what we did was develop a synthesis of the 19 frameworks. Let's put those together and see what we have. And this is what we did. And if people want to see this, if you just Google behaviour change wheel, you'll find it. And what we did was put the Kombi model at the centre of this wheel. Going back to my earlier point that when you design interventions, you start from understanding the behaviour in context, and that then points you in the direction of the interventions that are likely to be effective. So what we have are 2 layers around this wheel. The first are general intervention functions, and then looking at the 19 frameworks, it was very obvious that there was actually 2 layers, and the grey area are what we've called policy categories. So the following 9 intervention functions really summarise what were in all those frameworks. And here they are, starting from the top. We have education, persuasion, incentivisation, coercion, training, enablement, modelling, I mean role modelling by that, environmental restructuring, and restrictions. And then round the outside, the policies that support those intervention functions are environmental or social planning, communication and marketing, legislation, service provision, regulation, fiscal measures, and guidelines. So by starting with the behavioural diagnosis and the full range of potential intervention functions and policies, one can begin to get an idea of where one should and how one should be intervening. Now I'm about to show you a matrix which is in this paper where the 6 Kombi segments are down the side. So you have your behavioural diagnosis, you've assessed your implementation problem, and 1 or more of these are relevant, and then at the top of the intervention functions. It'll look horrifically complicated, and I'm just going to whiz through it. This is what it looks like, but for the sake of argument, let's take one of the findings. It's not my responsibilities. This is the part of reflective motivation. You look along the matrix here in the 4 coloured boxes. So any one of education, persuasion, incentivisation or coercion can help with that issue. Or another one, uncertainty about how to do this, which is to do with psychological capability. You look along there and you've got training, enablement and education. So you can build up the intervention functions from the findings. However, in all those studies, I think there were about half a dozen studies that I cited earlier in the talk, researchers called for guidelines, training and education. That's all they called for on the basis of those empirical findings. But there are many other options, as you can see here, and many of these would be very effective. So just before I finish, I want to end up with just one more level of complexity and detail. These are very general intervention functions. In the UK, our government's using this a lot to actually look at their current policies and say, well, actually, what are our current policies actually trying to do here? However, if one's designing an intervention, one identifies these general functions, there's then an issue, okay, but what do we actually do? What specific techniques can we do to actually enact some of these general functions? And quite a lot of my work has been done on identifying specific behaviour change techniques. And this started from systematic reviewing. When you look at published descriptions of interventions to change behaviour, they are so sketchy that you really don't know what's going on. It's a bit like if you were to read a description of a pharmacological intervention and it was described as a big red round pill. You know, that's basically the level of detail we're talking at, which is absolutely hopeless in terms of science and accumulating evidence, because you can't replicate, you can't implement things that have been found to be effective. It's amazing we get anywhere. So we've developed some taxonomies of behaviour change techniques to help people specify their interventions in detail. These are active ingredients within the intervention. They're observable, replicable, and the smallest part of an intervention that on its own, in ideal circumstances, can change behaviour and can be used alone or in combination. I've published several of these taxonomies in different domains, but over the last 3 years I've had an MRC grant, and we've just published the first of a series of papers. We've called it Behaviour Change Technique Taxonomy version 1 because we will be building data and gathering evidence, and there will be a V2. But this is in Annals of Behavioural Medicine, and it is composed of 93 items which have been put into 16 groupings by some empirical methods to make it more useful. Just to give you an idea of what we're talking about, here are some of the groupings. So if you look at number 1, first grouping, goals and planning, and you'll see there's several different techniques, specific techniques within that. So those are the first 9 of the 93. And just to give you an illustration, for each of these, so we take the very first one, there's a very detailed definition and some examples, which is needed if you're going to get good reliability for using this. And this gives an agreed standard method of describing interventions accurately, designing interventions, evaluating, for example, in factorial designs, because most of our interventions are complex, lots of small components interacting, and we need to identify which the active ingredients are and how they're working so we can go on and optimize interventions. And also for conducting systematic reviews, and finally for seeing are interventions being delivered in the way that they were planned. So, in summary, what I've really tried to stress is when one's applying behavioural science to designing interventions to change provider behaviours, or it can be any behaviours, start by understanding the problem in context, use a theoretical framework, consider the full range of effective interventions or potentially effective interventions and supporting policies, and then identify the behaviour change techniques for reporting and assessing delivery. And thanks to a couple of main collaborators in this work, my team and funders. Thank you very much.